starts for some of us, kind of reminding ourselves of what the jet is and what it does and what it can and what it can't do, and also just kind of how to be more efficient with this machine, about just how to use it better. And so if you have questions and stuff, you know, or, you know, some kid recently that he had, you know, something happened or whatever, just, you know, somebody's going to have the same question, you know, it's a really good discussion point. So don't feel bad about raising your hand and asking a question or interrupting me. So, you know. All right, so let's kind of get right into it here. You know, at first, let's remind ourselves of what the jet ventilator is and kind of the theory of operation and how it works. You know, the jet is a very gentle ventilator, okay, right? I mean, that's what high frequency is. Jets, oscillators, you know, they're very, very gentle. And, you know, high frequency doesn't mean high stress, high anxiety, people freaking out. The reason why it means that is because we put it on our sickest kids, right? That's why it means high stress, high anxiety. But these ventilators, you know, they were invented to prevent lung injury, not just treat it. Now, historically, we treat it, right? You know, we rescue mode type stuff with that there. But, you know, I honestly believe, you know, the more comfortable and confident, the more we do stuff like this and we learn about these machines, then we're not as afraid to get them started earlier rather than later. And that's always a good pattern for success, is to start it sooner rather than later. And, you know, the thing with using the jet, you know, it kind of, in the hierarchy of like where it falls often in many NICUs, as far as it being maybe like last ditch effort, last, you know, type rescue move, though, you know, it kind of, it's kind of hard to, it's easier said than done to say, hey, use it earlier rather than later, I guess. So, you know, part of what I want to start off with is talking a little bit about differences between a jet and an oscillator. And kind of identifying that, you know, when we have a kid that's kind of not doing so great, we may go to an oscillator first. But that's cool, that's great. But let's recognize the signs of when that may not be working, so that we can get them on a jet sooner rather than later, so that we're not maxed out at 20 parts per million and a jet pip at 50, and you know what I mean, just those high settings here. So the jet ventilator, now this picture here I threw in kind of as a fun little Easter egg. That's what the new jet will look like next month when it's released. It's half the size, half the weight of the current model. It has a few extra things. It's not what a lot of us want, which is kind of like the built-in one with the conventional and the blender and stuff like that. This is the intermediate step to get us to the jet that we all really want. But yeah, it's cute, it's fun, and I can legally talk about it now, so I was like, throw it in there. Okay, but look at the machine for what it is. You know, the jet is not scary. All the jet ventilator is a simple time cycle pressure limited machine. It's a pressure control bin. Hey, come on in. It's a pressure control modality, right? You know, if you think to the jet, there's a PIP. You dial in the pressure, and there's a set I time, and that's it. That's the bin. You know, so it really is just a good old-fashioned pressure control type bin. Now, what makes the jet a jet is actually this little VT tube adapter. When you change out the existing VT tube adapter with the jet one, up front, it looks like the obvious answer is, of the purpose of the adapter is to combine both the conventional circuit and the jet circuit together. And yes, that is a major reason that the adapter exists. But the adapter is actually what makes the jet a jet, okay? See, as those high frequency pulses are being created further up the circuit by the little patient box there, if you look at a cross section of the adapter, as those pulses come in, it goes through a little restriction right here. And then it turns downward and gets squirted straight down the ET tube. And you know what happens to a flow of gas as it goes through restriction? Well, it speeds up. It gets a lot of velocity, a lot of momentum. And that's what creates what's called flow streaming in the airways, okay? Just kind of think of it as like super uber fast laminar flow, okay? Very small volumes delivered very quickly. It creates flow streaming, okay? And so the flow streaming penetrates through the middle of the airways. It penetrates through the middle of the dead space. It doesn't have to necessarily push all the dead space out of the way, like pretty much all other ventilators do. And so that's what creates the jet streams, is that. Exhalation, you see, occurs around the gas that's coming in. Exhalation is a little slow with the jet because it is passive exhalation. It doesn't mean it's not effective. It just is slow. But that's the idea, at least what the mathematical models tell us of what the jet gas is doing inside the airways. And so it is a little bit different, really, than neovents. So when we look at differences between an oscillator and a jet, I believe that every hospital needs both machines. Okay, yes. Some patients will respond better to one or the other. It really just depends on the disease process that you're treating, that you're taking care of. Okay, and what will help us kind of decide which one to take out of the closet really does depend on the baby, the disease process, but also our knowledge of mechanically the differences between the machines. Okay. And so most often, when I ask what are differences between the two machines, people refer to passive versus active exhalation as far as being a difference, and it is. It's kind of like the most popular difference, the popular answer, but I don't think it's the biggest difference. What makes a difference pathophysiologically to our patients are the next couple of lines down. It's how the machines actually work. Remember, with an oscillator, it's a percent cycle machine, usually 33%, which means your IDE ratio is always a 1 to 2, and it also means your tidal volume delivery is now dependent on your hertz, okay? And the simplicity of using an oscillator is what I love about it. I love the kind of the 3-knob control type thing, but everything is kind of tied together too, though. What if I want a long exhalation time? Well, I can go down on my hertz, but that also means I'm giving a longer inspiratory time, which also means I'm giving more volume. Well, what if I want small volume but a long exhalation time? Well, it's kind of hard to do, And that's where sometimes the jet can come in and help, especially with those patients where they're overinflated, they're gas trapping, certainly if they have established air leaks or something like that. The jet has just a set fixed I time, 20 milliseconds, that 0.02, that's it, that's the breath. And because the I time is set and fixed, that means when we adjust the jet rate, we can get different IDE ratios. And that's real important because our babies in here are gas trapped, plain and simple. They have long expiratory pulmonary time constants due to their lack of elastic recoil. And we need to allow sufficient exhalation time. With it being a time cycle machine, that also means now that my tidal volume delivery is independent of my rate. It doesn't matter what rate I'm on. My tidal volume delivery is dependent on my delta P and my inspiratory time. Okay, so yeah, they're a little bit different. There's a difference in flow rates and kind of. I call an oscillator mini bolus stacking because as that piston pushes in and pulls out, it's kind of like one on top of another. So I haven't trademarked that yet. I'm working on it. But yeah, that's what it is. A difference in gas delivery as well. When you look at the pressure waveforms between the two machines, the jet up here kind of presents a traditional kind of pressure control type waveform. But remember that this is high frequency, which means it's gentle. The amplitude, your applied delta pressure, dampens and attenuates dramatically as it goes down the airways. So as we get down here to the distal airways and alveoli, as your airways branch off and become smaller and smaller and smaller, resistance increases. And as resistance increases, your applied delta pressure just drops off like crazy. Okay, and so it's often been said that the pressures down here are less than 10% of what's actually dialed in. Out there. That's how much it actually drops off and attenuates here. An oscillator, of course, has a sinusoidal pressure waveform that's centered around their mean airway pressure that's fixed there. And then the jet has the PEEP stays constant, the PEEP is fixed. And then as the delta P gets smaller, the mean decreases slightly there too. And so, yeah, they really are different machines. They're both high frequency. There's a lot of similarities between the two. They both should be used early. They're great. They're both great used preventatively, prophylactically. They have a little 25, 26 weeker. We need to be as absolutely as gentle as possible. Perfect type babies to place on either a jet or an oscillator. there. But when it comes to certain disease processes, they really are different machines, and why one may make a difference versus the other. So who then would really benefit from being on a jet? You know, is it just for air leaks? Is it just for an x-ray that looks like that with all that gas over there? Well, if this is your x-ray, I hope that kid's already on a jet, you know, and I hope we get the chest tube tray out, okay? But yeah, by far and away, kids with established PIE, air leaks, gross overinflation, these are jet kids, okay? And many facilities I visit, you know, at the first sign of gas trapping and overinflation, they think about bringing the jet out of the closet. They don't wait for the CO2 to get to 120 before they do it, you know. They see the x-ray, they see these changes starting to take place, and then they're not in a position of like rescue mode mentality. They're kind of in a position of maintaining and controlling, if you will. And that's kind of where sooner rather than later comes into play, which is why number two, you know, these machines were invented to prevent lung injury, you know, not just treat it. And so again, earlier the better for these patients, for our little babies that we take care of. We can reduce that lung injury. Often non-homogeneous disease processes respond well to the jet. Hypoplastic lung, CDH type patients there, pneumonia type process. Now, you know, if you think about homogeneous type processes, I think oscillators work very well for those types of patients. You get a pleural effusion, maybe, you know, edema, a lot of fluid retention, a high drops baby, something along those lines. That 1 to 2 IDE ratio with the oscillator and kind of the higher application of mean airway pressures would certainly suit those patients a little bit better there. But non-homogeneous disease processes have responded very well to the jet. Meconium aspiration, secretion, pneumonia type processes where you have lots of secretions. The long exhalation times can work very, very well to removing the secretions that haven't. Number 5 is one where we're seeing a huge growth in use of the jet. Patients who are hemodynamically compromised. And these are ones where I see develop a refractory hypoxemia type picture. Okay. So often, you know, we have a little baby who's not doing so great. We'll throw them on an oscillator. And then you have like 2-3 days where things are pretty cool on an oscillator, right? And then by the 3rd day, the x-ray just starts to do this and blow up a little bit. We start increasing mean, and we increase mean a little bit more, and we're cranking up the FiO2. And then we start to develop this kind of hemodynamic compromise here with the higher intrathoracic mean airway pressures. And so, you know, because the jet's able to get good gas exchange at lower overall mean airway pressures, if we can reduce that hemodynamic compromise and help VQ matching, yeah, it can certainly help. And then kind of number 6, when everything else fails and we don't know what else the hell to do, pull out the jet, okay? I mean, it is, because it is so different than everything else out there, it can work, it may work, it may not work, but we're not gonna know unless we try. You know, we're not gonna know there. And so, you know, and I've seen it, I think you guys here have too. I've seen it work on kids that were just really, really bad. And can't explain why, but it just did, you know, so it's always worth a shot. So for many of the facilities that I visited over the years, you know, how they use both machines, this is kind of their mentality of using it, you know. I think, you know, if you're using, you know, if you have a little 25 weaker, I think using a jet or an oscillator right off the bat is perfect. They're great at preventative lung injury. You know, most facilities just wait to pull out the jet until the oscillators show that it's not effective anymore, can't work, and that's fine too. But you know, I don't want the mentality of the jet being a last-ditch effort to be what we take away. You know, it can be used earlier. It should be used earlier, and if we use it earlier, then we're not using crazy pressures and crazy strategies to try to save this kid. We're in more control of the situation. And that always works out better for everybody. Yeah. All right, so the basics of patient management with the jet and also the conventional ventilator with the jet here, they're really no different than any other machine you've ever taken care of, any other ventilator. Oxygenation is always a result of mean airway pressure. PEEP is your primary control for that mean airway pressure, okay? But with using a conventional ventilator with the jet, we have the ability to deliver these sigh breaths for lung recruitment. Okay, and they are incredibly efficient and effective towards getting our lung volume back once we have atelectasis. So the jet is all about ventilation. It's your chest wiggle, right? It's all about blowing off CO2. Delta P is your primary control for that CO2. The jet PIP is what you will use to adjust your delta P as you need to. And then there's also the jet rate and the jet inspiratory time that we can also use to in our patient management to control CO2. And we'll talk about those things later. So this is kind of a common phrase that I hear quite a bit, and many years ago I believed it too. You know, if you need oxygenation, go with an oscillator. If you need ventilation, go with the jet. You know, the jet's a really great ventilator, and the oscillator is a great oxygenator. Well, that's true, but don't you need both, right? I mean, one may be worse than the other, but I'd like to have both, if that's okay, you know? And the thing about oxygenating with the jet is that you don't oxygenate with the jet. You oxygenate with the conventional ventilator that's with the jets, okay? And so even though you have two ventilators at the bedside, you have a conventional, you got a jet, separate the two because they do two totally different things. All the conventional does is oxygenation, okay? The jet is a ventilator in the pure sense of the word ventilator. It blows off CO2. So if you have a CO2 problem, we're going to touch the jet. If you have an oxygenation lung volume problem, we're going to touch the conventional. And so even though I got these two at the bedside, draw a line between the two. They do two completely different things, but really simplify it. Are there times where they cross over a little bit? Yeah, sure. I mean, if I have a high CO2 because I have atelectasis, okay, I'm going to go up on the jet all I want. It's not going to make a difference. Okay, I need to correct the atelectasis here and then my CO2. But the overall, the idea and the thing to kind of simplify is to really look at it this way. There, the jet is just your chest wiggle. It's the primary control for CO2 there. And let the conventional ventilator provide your oxygenation. So the role of the conventional ventilator is to provide that PEEP and mean airway pressure. That's really the bigger picture that we're after, is that. The lung recruitment, the sigh breaths, which we'll chat about here in just a second. But here's another very important thing that the conventional ventilator does. It provides the biased gas flow for the baby to breathe spontaneously. It gives him that fresh gas support that he needs. You know, the jet, it's a very selfish machine. It only puts in enough gas flow to reach its own PIP, and that's it. And we're only talking a liter, maybe 2 liters a minute. So obviously the baby needs his own fresh supply for him and his spontaneous breaths. And that also comes from the conventional ventilator. All the exhaled gas goes out to the conventional circuit. So a conventional ventilator does quite a bit. But here's the beauty of using the conventional ventilator. There are things that you can do with big volumes and big breaths that you can't do with high frequency breaths, like recruit atelectasis. See, when you have atelectasis and you apply pressure, you've got to get past the critical opening pressure to pop open the alveoli. That's something high frequency will never do. It's too weak, it's too gentle. Remember, lung C less than 10%, what's actually dialed in type stuff. Yeah, so that's where we supplement that with the conventional ventilator. And then of course you need to make sure you have enough PEEP on the tail end to prevent the collapse there. And if I could simplify it optimally, this is where high frequency would like to hang out, just where the bottom part of the delta P is just at or above your peak level. This, yeah. Well, if I have atelectasis, you know, a lot of times we just turn PEEP up. You know, that's true, but sometimes it's not always the right answer, especially when it comes to using it with the jet. See, if all I do is increase PEEP up, which brings up my mean, it doesn't guarantee that I'm hitting the critical opening pressure to pop the alveoli open. Because PEEP is at the bottom end. PEEP prevents de-recruitment. It doesn't necessarily recruit. What recruits is this. PEEP helps the recruitment by not allowing the collapse. Okay, that's the beauty of using the conventional ventilator. It provides the size, if you will, to get past this. So, you know, after suctioning or something, and the patient's decompensating a little bit, it's a great time to use the sigh breaths. You know, anytime the patient's just having a spell where sats are falling, decompensating, side breaths can help with that. And certainly if you have x-ray and you have evidence of atelectasis, side breaths can help with that. So it's very, very useful and helpful. Now, the thing with the side breaths though is, remember, they are normal conventional ventilator breaths, which means we can have a PIP that's too high, which means we can possibly give more volume than what the baby needs. And so traditionally how we've approached using the side breaths, if you will, is overall to give a high PIP over a short period of time. So in other words, on your conventional ventilator, a lot of folks, a lot of facilities will stick with their 0.35 or 0.4 second TI and deliver a high PIP with that. Well, what's actually more gentle for the lungs is, instead of giving a high pressure fast, give a lower peak pressure over a longer period of time. Because then we're not getting up here to the lung injury zone there. If you have atelectasis and you deliver a high pressure fast, where's that gas going to go? Well, it's going to go to the parts of the lung that are already open. It's not going to go to the allostatic parts because there's not enough time. We're delivering it too fast. The allostatic parts of the lung have exponentially longer pulmonary time constants. It takes more time for those parts of the lung to open. So be more gentle. That's a whole key word. Be gentle with the side breaths. Don't do a high pressure fast. Do a lower peak pressure, but over a longer period of time. 0.5, 0.6, 0.75, even a 1 second inspiratory time. And your PIP above peak, it only just needs to be at a very minimal amount, okay? And I know that's a gray area, but it really is a gray area because every baby is different. What total PIP would I set this at? What would be a normal PIP for a baby that size? What's just a normal type PIP for a baby that size? You want to visualize just a nice little sigh, a nice little chest rise, but that's it. Nothing more than that. Because if we do more than that, then we're going to be way up here, okay? And so, so for a little 26-weeker, maybe my total PIP only needs to be 17 or 16. And sure, for a chronic lung type baby, it's going to be a little bit more. And I know it's very subjective, but the idea behind it is not to overdo it, okay? Because those background breaths, they're great for recruiting the lung, but they're bad for lung injury, right? They're bad for air leaks, and if we use it and abuse it too much, then we're not doing the baby any good, okay? The rule of thumb that I go by is use them when you need to and don't when you don't. If lung volume looks good and you don't have atelectasis, then we don't need to necessarily be on a backup rate. Ideally I would like CPAP for those types of patients. But if we do have an increase in oxygen requirement, we get an x-ray and we do have atelectasis, okay, then I can use the background rate. But the idea is to use them temporarily. Think of it as a temporary lung recruitment maneuver. 15, 20, maybe 30 minutes. Recruit the lungs back, get our sats back to baseline, and then bring that back down towards CPAP. Now on the servo, it's a little tricky because you can't just turn the rate knob to 0. But what you can do is dial down the pressure control, right? Your PC above PEEP. So if normally your PC above PEEP is 10, for a total PIP of 18, let's just say, bring the PC above PEEP down to where it's only 5. So then, even when that rate of 3 comes on, your total PIP is only, your total PIP is only 15 or whatever, and it's not a lot, So the key with the background rate is use it when you need to. If you don't have atelectasis and you don't have any problems like that, then back off and just be as gentle as possible, because otherwise you're unnecessarily putting in large volumes that don't need to be there. I may have gas trapping on x-ray. I can dial in the jet to try to treat that. But what good is that strategy if I keep putting volumes in on top of the strategy that I'm trying to develop to get rid of it, to help treat the air leaks? Okay. So when we talk about optimizing PEEP and how much is too much and things like that, it's always a good idea to concentrate on the mean airway pressure. PEEP is just your primary way to get mean airway pressure, but mean is always the bigger picture that we should always look at, okay? And so here's a really nice rule of thumb that I've used for plus 20 years now. The jet just running by itself, granted at the default settings, but the jet just running by itself only puts in 3 of mean airway pressure. That's it. So when you're trying to optimize PEEP, and we're discussing how much PEEP we should or shouldn't be on, the real question is, what mean airway pressure do you want to be on? From that, we'll figure out how much PEEP you want to be on. So for my little example here, my baby likes a mean airway pressure of 12. The jet, just running by itself, only puts in 3 of that 12. So that means my PEEP will be about 9. Okay, that's how you kind of optimize PEEP. It's really optimizing mean airway pressure. Remember what we said earlier about how the jet doesn't oxygenate? No, it doesn't oxygenate. It only puts in 3. Of course not, right? But it does put in a little bit. Okay, so target mean airway pressures. And where this really helps is when you first transition to the jet. When you're coming from a conventional to the jet or the oscillator to the jet, you want to initially kind of match mean airway pressures and then gently titrate the baby down to where you'd like them to be. But don't bottom them out and fight to work your way up. But that's what happens often, okay? You know, kind of an example, you know, a baby might be on he's on an oscillator, he's on a mean of 15. We start to see little blebs or air leaks, so let's go to the jet, okay? So we pull the jet out, we're gonna go to the jet, and you know, we have an order for a PEEP of 6. Well, if your PEEP's 6, your mean's only gonna be what, 9. You're gonna go from a mean of 15 to a mean of 9. Well, what do you think's gonna happen to our baby? Of course he's gonna decompensate. And then we're gonna be fighting to work our way back up again, and everybody will be mad, and you know, I know how it works, you know. Everybody's blaming the jet, it doesn't work. Does the jet not work, or do we not work, right? Okay, so this is where that can help you, like in that transition, is to say, hey, I may not need a mean of 15, but I'm gonna shoot for like 13 to start with. And to get that 13, my PEEP's gonna be about 10 to start with. And then once we've successfully transitioned over, and you know, things are calm and say, okay, then we can start to titrate our way down to where we want to be. Because the whole point of going to the jet is to be at a lower mean airway pressure anyway, right? So bring it down. Start high and then gently titrate down. Just don't bottom them out and fight to work your way up. Okay? And that's where that really helps. And we have this optimal PEEP algorithm that can help kind of find that. You know, we have to be as dynamic as our patients are. And so if you're using a background rate and we start to decrease the PC above PEEP, or we turn the rate down, watch your sats. If your sats drop because you took away the lung recruitment, what does that mean? PEEP. Our PEEP's not high enough. Our sats drop because we took away those recruitment breaths. So we can recruit the lungs again, but now increase PEEP by 1. And so now when you go back to CPAP, your PEEP is 1 higher than it was before, and then you just watch your sats. If your sats stay up, okay, cool, you've optimized PEEP. All right? And so this little page here is in the little, with the jet, it's probably in the RT room, is a little quick reference guide. It's like a 10-page laminated spiral thing. This little algorithm's in there. And it's a really cool thing to run through. You know, when I look at patients, especially if they have like an increased FiO2 requirement of like 10% or more, you know, a sustained increase of 10% or more, something may have changed, and we may need to adjust our PEEP accordingly, you know, with that there. So, and all we need is just a few minutes at the bedside and our eyes on the sats, okay? But yeah, if the sats drop and because we take away the recruitment. So a lot of times we hear on the hotline and when I visit places, I hear, well, we leave that rate on and we leave the pressures high because the baby likes it, he likes it. No, what he likes is his lungs not collapsing. That's what the baby likes, okay? You know, and if we can optimize people a bit better, then we can get away maybe, get away from those side breaths that don't need to be there. They're very useful. They are very wonderful, but we can overdo it.
Before you go to this slide, can you go back?
Yes, sir.
So what exactly do you mean switching from IMV to CPAP mode? I kind of lost you there. Do you mean
getting rid of the background rate?
Okay.
Yeah.
All right. Okay.
Yeah, getting rid of the background rate. Or like in our case with the servo, you can leave it on a rate of 2 or 3, but dial down the PC above
okay.
peak.
Okay.
What's the maximum rate that you usually use?
5. There will be times that I'll go maybe to 10 if a patient is actively crashing. You know, then I'll go to 10, but that's the first thing I got to turn down, of course, when in there. But yeah, you know, and the rate, whether it's a rate of 3 or a rate of 5, either one, I think less is better. But what I'm more concerned about is the pressure control above peak with that rate. You know, that's what you know. I'd rather be at a rate of 5 at a lower PIP than a rate of 3 at a higher PIP. If that makes sense. So, but yeah, in this case, my CPAP is really just bringing down the PC above peak to where it's there. But that's exactly what it is, just the background rate. You know. And so ideally, that's what we'd like to look for. Now, how high is too high of peak? Because, you know, problem is that I'm looking at an X-ray that's really overinflated, and, you know, things like that. And I get all of that. We really do. My limit of peak, I have to let the baby tell me that. You know, I let the baby tell me when they've had enough. When I have hemodynamic compromise, because I've gone up on my peak, and then my blood pressure drops and heart rate goes up, okay, that's my limit. But I have to let my baby tell me that. And I know sometimes, you know, as an RT, sometimes I'm more afraid of turning that knob from 8 to 9 than the baby is, okay? But yeah, you do. You need to let the baby tell you that, you know. So part of the thing here, though, is you can't get so wrapped up into treating what's wrong that you forget about what's right and what's working good for you. And we do this often. I have blebs over here, overinflation over here, turn peak down, okay, the next thing you know, white out atelectasis over here. You know, and it's like, man, I had good parts of the lung working for me. It's I know it's a tight fence to walk, but that happens a lot. And so sometimes we look for other avenues maybe to lower the overall mean airway pressure, but not necessarily lowering peak. Okay, and we'll talk about that with the jet rate in a little bit. So the thing of why PEEP is so incredibly important, it's not just an oxygenation thing. PEEP actually enhances ventilation because of airways resistance. With high frequency ventilation, both jets and oscillators, the greatest impedance to effective delta P delivery is the airways resistance. Okay? So if the airways are smaller and resistance is high, your applied delta pressure just drops off like crazy and it's ineffective. So if we have PEEP dialed in right, not only are we making it easier for the jet gas to get downstream, but more importantly, the gas that's trapped can get out. That's the important thing, because airways will shrink on exhalation. And airways shrink on exhalation, resistance goes up. And when the resistance goes up, we make it harder for exhalation to occur. That's why a lot of times it's really easy for these kids to get overexpanded on X-ray. All right, so now that we've got oxygenation down, let's talk about ventilation, and that's about the jet. With high frequency, remember our CO2 elimination formula changes a little bit. It's no longer just equal to your minute volume. Your CO2 elimination is now proportional to rate times tidal volume squared, okay? And so what that essentially means that is any tiny change that I make to my volume delivery will have a much, much more profound effect on my CO2 elimination than changing the rate ever will. So the most efficient way, the best way to change volume delivery on the jet is to simply increase the delta P. You go up on the jet PIP, okay? Now you can increase your volume by also increasing the jet inspiratory time, because it is just a straight up pressure controls modality, right? So if I increase my high time, I deliver more volume. But also, you can also look at the servo pressure on the jet, which tells you essentially how hard the jet's working to deliver that volume. An increase in servo pressure means that you are delivering more volume. You know, that's what we'll talk about in a little bit. So Your primary control is the jet PIP. CO2 is high, go up on the jet PIP, okay? Create a larger delta P. Do remember though, it is a delta P. So if I go up on my PEEP by 2, what did you just do to your overall delta P? It shrunk by 2, okay? So you may need to go up on the PIP to compensate. Do you have to? No, I mean, only if the baby says he needs to, you know, but that is something to consider, okay? And why is tidal volume so important? Well, I did this little chart here to kind of demonstrate why that rate times tidal volume squared makes a lot of sense, okay? If the jet delivers anywhere from 0.4 to 0.9 cc's as far as what it's been studied to look at, okay? So I just picked 0.7 as a starting point. If I increase my jet PIP and I increase my volume delivery, if all I do is increase it by 1/10 of a cc or even more, look at this tremendous increase in your overall CO2 ventilation. That's why changing the volume and even small changes in the volume makes a big difference in our overall CO2 elimination, okay? Now, the technology does exist for us to measure these. It's just not implemented in hospitals yet, okay? But and someday the day will come where I can monitor breath by breath what my volume is from the high frequency machine. But the idea is what I want you to take away from this chart is yeah, that's why delta P works. A change in pressure creates a change in volume. Good. So where does the rate come in then? If going up on the jet PIP and creating larger delta P, doesn't the rate have some effect? Sure it does. Where the jet rate has an effect has to do with exhalation time. It has to do with making sure there's enough time for exhalation to occur. When you first turn the jet on, you're at this 1:6 ideal ratio, right? It's just a middle of the road type thing. And that works well for most kids. A lot of times we don't ever have to change the jet rate, okay? But yeah, there's gonna be times where it's really advantageous to change the rate and to lower the jet rate. Look at your x-ray. Ask a yes or no question. Would your patient benefit from a longer exhalation time? Yes or no? If the answer is yes, then being at a lower jet rate is a good idea. You get a longer IDE ratio, more exhalation time, okay? And if the lung volume looks good, then don't change the rate, leave it alone. The rate on the jet is something that you kind of set and you forget. You let it ride. It's a slow and steady wins the race mentality, okay? Now,
only just put it on 420 and forget about it.
Yes, but I'm also going to say no. Here's why. If I've been at 420 for 2 days, 3 days.
I'm saying in the old days.
Oh yeah, the old days. Oh yeah, the old days. Yeah, we never touched the rate. Right, right. But yeah, if I've been on 420 for 2 days, 3 days, and my X-ray today still looks as overinflated as it did 2 days ago, then that's all the evidence I need to go lower. Okay, I've been on 420, the X-ray's still overinflated, let's go down to 360. And then if you've been at 360 for 2 days and that X-ray still looks overinflated as much as it did, then go down to 300, okay? That's the whole idea. So that's when I would change the rate, is really based on my X-ray. Let the X-ray tell you what to do with it there. Don't chase the CO2 with the rate, because that's where people get trapped. They have a high CO2, you know, they're grossly overinflated, but they have a high CO2. They'll go up on the rate and get a blood gas in 20 minutes. And will that blood gas be good? Yes, it will. I'm not worried about the blood gas in 20 minutes. I'm worried about the blood gas 6 hours from now, okay? The more they keep going up on the rate, they shorten the exhalation time, making the gas trapping worse. That's why, you know, and this is not any different than what we do every day, which is the right ventilator strategy that fits the disease process we're treating. Just look at the baby, look at your X-ray, and just, again, just would my patient benefit from a longer exhalation time? Then being down here would be where you want to go. Okay. So, yeah, there we go. Now, here's a secondary advantage to lowering the jet rate. Right here, the mean airway pressure. Okay, see, I'm overinflated. I kind of want to lower mean airway pressure. So by lowering the jet rate down, not only do I get a longer I to E ratio, but you also lower mean, but you didn't touch peak to do it. Remember what we said earlier about how the jet puts in 3 of mean? Well, that's up here at 420. Well, if I drop it down to 360 and certainly to 300, now the jet's not putting in 3 anymore, it's only putting in maybe 1.5, maybe 2. So you've lowered the mean airway pressure, but you've left PEEP alone. You remember, PEEP's there to extend the airways open to reduce resistance. And so there's a nice little benefit to being at a lower jet rate when you have air leaks and you have that overinflation, is that too.
What if your issue is CO2 retention and you've already gone up on your delta P and you're at a delta P where you are not quite comfortable going up anymore?
Mm-hmm.
What's your strategy with the rate? Is it the same, thinking with minute ventilation? I'm just trying to, see if it translates, or if it doesn't, would you go up on the rate or how, if you're still trapping CO2?
If I can go from 360 300, I would, because that's gas trapping, because that's what the X-ray is telling me to do. But there is also something else that I would do, which we'll talk about at the end, which is actually change the jet inspiratory time.
Okay.
There too. So overall, we talked about using the conventional ventilator to open up the lung, enough PEEP to keep the lung open. Mm-hmm. Once you do these two things, then the jet can do its job. But the jet is worthless if we're not doing these two things first, okay? How successful you are with the jet is first determined by how successful you are with the conventional, okay? So optimizing that lung volume and optimizing PEEP is crucial to success there with the jet. All right, so with the jet, I mentioned servo pressure a little bit earlier, and let's dive a little bit more into what that servo pressure is. For me being an RT, it's a number that drives me crazy because the alarm goes off all the time. Okay, well, what does it mean, and what is it really doing? Well, servo pressure is what it is essentially gas flow going through the jet circuit. Okay, we monitor it as a driving pressure as opposed to liters per minute, like we're normally accustomed to here. But that's all it is essentially gas flow. It's a servo mechanism because it's feedback controlled. The jet looks at your set PIP, then it looks at the monitored PIP, and it will automatically adjust its flow to making sure the two are the same. And so it's going to change. It's a variable flow mechanism. As lung compliance and volume improves, you need more gas flow. So the servo pressure automatically adjusts itself to fill that volume and fill that space. It compensates for states. If I'm at a set PIP of 20, and I reposition my patient, and now I have a leak around the ET tube, and instead of getting 20, you're only getting 17, the servo pressure goes up to bring your 17 back to 20 to compensate for that leak. And the opposite's true too. If we kind of right main stim a little bit, and maybe your monitored PIP jumps up to 28, jet says that's too high. I'm supposed to be at 20. And the applied pressure or gas flow, the servo pressure will come down to bring the 28 back down to 20. So that's why that number is always moving. It's supposed to be. Okay, it's always moving up and down to making sure you're getting what you're set at. So I kind of did this graph many years ago to kind of put it in perspective. There's my current baby's lungs, and there's my target PIP. If I have improving compliance, maybe I did some lung recruitment maneuvers and the lungs have gotten better. Maybe I gave surfactant, something along those lines. As lung compliance improves, initially your PIP drops because the given flow is not enough. But then the servo pressure will go up to bring the pit back up to where it's supposed to be. And the opposite's true as well. If maybe my baby becomes septic or something and the lungs start to shrink up, all of a sudden the PIP is too high, the servo pressure will come down to bring it back to its target value when it's supposed to be. So it is a variable flow mechanism. That's what it is. There's not a bias flow, it's a variable flow, okay? The jet's always adjusting that flow up or down to making sure you're getting what you're set at. And so here are some of the most common things that you'll see as far as why servo pressures would change. You know? And it kind of starts to make sense if you think about it, you know. And especially like a pneumo where I have an active leak. Well, it's a leak, so servo pressure will go up to compensate for the leak. But if it turns into a tension pneumo, well, then all of a sudden there's no more room for the gas to go. So it would do the opposite. You know, day to day, I look at suctioning about whether my patient needs to be suctioned or not. The servo pressure can help tell you that. You know, this is why it's important for you guys to know with your baby what his baseline is, what his baseline servo pressure is. Okay. Know that, hey, at a servo of 2.4, you have good chest wiggle, CO2's good, you know, that's our happy place, okay? And so that when there's decompensation and you come in and the servo pressure is only 1.8 instead of 2.4, you know it's supposed to be 2.4. That's why you don't have chest wiggle. That's why we're starting to decompensate. And I'm telling you, a lot of times, just a simple repositioning, get things back midline, maybe just a slight turn of the ET tube. Oh, then all of a sudden you got chest wiggle again and the servo pressure comes back up to where it's supposed to be, okay? So I know it's on your chart, and I know we chart and document it, but get to know with your patients day to day what their baseline is, and that should be part of our shift report, you know. It's not just the settings that are on, but know that, hey, today his servos have been running 2.3, 2.4, so that you have that established baseline of where it's supposed to go. Right?
I have a question.
Yes, sir.
How much change in servo pressure should we see over a 12-hour shift before considering making changes? I mean, if we see a change of about, you know, from maybe 1.8 to like maybe up as high as like into the 4 range, 4.2.
Yeah, that's probably too much there.
Sure.
Answer that, you know, there. But I will tell you, the alarms on the jet, the default alarm limits are plus or minus 20% of the baseline value. Okay. So for easy math, if my servo is 2.0, then my upper limit is 2.4 and my lower limit is 1.6. Okay. I think that 20% is tight, especially now that you know, we don't sedate and paralyze nearly like we used to at all. And I want the baby to breathe spontaneously. So I think by giving him a few more tenths range on your limits would be good. A change by 0.5 or more, I think I need to look at. You know, I would kind of be concerned by that. And so that's kind of about where I may set my limits. Is 0.5, 0.6, so along those lines there. Just because they're hitting the upper or lower limit, though, may not mean that there's anything wrong. It just may mean that we need to adjust we have a new baseline. If you watch it closely, your baby laying supine is different than him laying prone. Him laying right side up versus left side up. And so if my normal of him laying supine is 2.4 servo, and then we flip him over prone, my new normal might be 1.9. Well, if the old alarm limit is still set at the older 2.4, you know, it's going to be going off all the time. Is that a big jump? Sure, that's a big jump in servo, but the reason is because we changed position. So the servo pressure is dependent on pulmonary dynamics. It's dependent on your delta P, on your PIP. If you increase your PIP, the servo pressure goes up because it has a larger delta P to compensate for it. As you wean the PIP down, the servo pressure will get less because it doesn't have to work as hard to achieve that delta P. So you got to factor in all of those things. But yes, a jump from 2 to 5, 2 to 4, that's a really big jump. I think anything more than 0.5, 0.6, we need to look at and investigate and see why it made that big of a jump. So I hope that kind of answers it.
Yeah, thank you.
In a great area. But you know what? It actually kind of leads into this slide here. We've been talking about how servo pressure is a feedback mechanism from the baby to me, right? Well, let me show you about how you can use it to be more efficient with the baby, with ventilating with the baby. We create a change in pressure that creates a change in volume, right? We go up on the PIP to create a delta P, and that creates a delta V. Well, what on the jet kind of indicates how much volume the jet's delivering, or what can represent that? Well, that's the servo pressure. You know, The servo pressure is how hard the jet's working to deliver that delta pressure. So when I go up on my jet pip to blow off CO2, I want to see a change in the servo pressure, okay? To know that you've made a clinically significant enough change. If CO2s are in the 70s, 80s, and you need to bring it down, you want to see at least a 3/10 change on the servo pressure. Okay? If you go up on the pip by 2 or by 3, and that servo only goes from 2.5 to 2.6, you didn't really do anything. Don't even bother getting a blood gas. It's not going to be any better. Okay? But if it goes up at least by 2.8, 2.9, then you've made a big enough change that can make a difference. Okay? This saves time. It saves blood gases. You know, because often the routine is we'll go up by 2 or 3 on the jet pip. You'll get a blood gas. The servo didn't go up by all that much. CO2 is not going to be much better. So let's go up by 2 again. Let's wait an hour, get another blood gas. It's not that much better. We go up by 2 again. I mean, here we are 6 hours later, 6 blood gases later. We may finally get to the pip that we could have been at much earlier in the day had we kind of been tracking that a little bit. You know. So the idea is to kind of take whatever his normal baseline is, you know, and I guess for this case 2.5, and say, I need to go up on the pip till I see that become a 2.8. Okay, now, the thing about it is that it is so dependent, of course, on the baby we're taking care of. Because on a little 26-weeker, a jet pip of 2, change of 2, it'll do that easy, right? But now, think of that beat up chronic lung kid. His lungs are so beat up, it's going to take a much larger change of pressure to create that change of volume. Okay? That's where you can use that as a tool. So going back to kids where we keep cranking up the pip and cranking up the pip, it feels like we're really increasing the PIP. A lot of times, yeah, we're increasing the pip, but the reason why the CO2 is not coming down is because the servo is really not changing that much. If the servo pressure is going up when we make our pip changes, yes, then the jet is delivering more flow and delivering more volume there. So what do we do when we do get stuck there with the pips being in the 40s and things like that? Well, that's where the I time comes into play. I know historically we leave the I time alone at 20 milliseconds, you know, and I mean, gosh, you know, never ever touch it. Well, you know, there was a time we never changed the jet rate either, right?
Mm-hmm.
But now we change it all the time. Well, now it's time to start thinking about changing the I time. And that's because it all has to do with pulmonary time constants. You know, you're trying to deliver a certain volume to the lung. It takes time to do that. And on some kids, especially the chronic lung, beat up, inflamed airway patient, his required pulmonary time constants, especially the inspiratory pulmonary time constants, are just 0.02 on the jet. It's too fast. It's too fast of an inspiratory time to effectively deliver that delta pressure downstream to where it needs to go. So it certainly makes sense with these different disease processes that we try to take care of here, you know. And you know, the jet, the default setting of 20 milliseconds, it works well for like 90% of the kids we take care of. You know, part of the reason is because if I'm dealing with some PIE injury or BPD, you know, whenever we're trying to treat that disease process, you want to make sure with your inspiratory time that you fall way short of the range of time constants. Well, at 20 milliseconds, it falls way short of the 50 to 80 that it's supposed to be at, you know? So that's why it works by default, just kind of right out of the box that way, okay? But the thing is if I go up on my inspiratory time, doesn't that change my expiratory time? Sure, absolutely it does. Does it matter? Not really. Here's the reason why. Here's our top, the top line is the default setting of 20 milliseconds. The first step that I would take when changing the jet I time is I'd go from 0.02 to 0.026, okay? You can go to 2.2 or 2.4. Those are small increment changes, just not a clinically significant enough change, okay? If you add 6 milliseconds to 20, that's a 30% increase in your inspiratory time. Take away 6 milliseconds from your exhalation time, that's only a 5% change. Your IDE ratio goes from a 1 to 6 to a 1 to 4. And if all you do is look at the IDE ratio it appears as if you've lost a third of your exhalation time. But did you really lose a third of your exhalation time? Not anywhere close. Okay. Even if you max the jet out, this is the biggest I time that goes is 0.034. That's a tremendous jump in your inspiratory time. And this isn't a NICU kid. This is a PICU kid here, okay? NICU kids will be right up here. But the point is that that's only an 11% change of the exhalation time. Your IDE goes from a 1 to 6 to a 1 to 3. But did you really lose half of your exhalation time? No, you didn't. So the IDE ratio window on the jet, when you change the inspiratory time, it'll display this. But you don't, it makes it look worse than what it really is. You know, I joke around. The IDE ratio is my 13-year-old daughter. A little over dramatic and a little overdoing it sometimes, okay? And that's kind of what it is. It shows worse than what it needs to be. Now, if I go to a 1 to 4, can I lower that rate down to get, yeah, you can, but you don't have to. Here's the reason why. You can have the longest exhalation time in the world. What good is it if you can't effectively put inhalation downstream to create exhalation in the first place? Exhalation is all about pressure gradients. A higher pressure gradient here than what's up here. And if we're more efficient and effective on the inspiratory side of things, the expiratory side of things will just follow in suit right along. So yeah, I still want to keep a healthy respect here. You know, I think having a 1 to 4 would be where I would put my limit, if you will. You know, if I do end up going down here, then I would drop my jet rate maybe to 360 to kind of get this back to a 1 to 4-ish. But yeah, you do lose some of your exhalation time, but it's not as bad as you think it is up front. So when would I really look at doing that? Well, it's the patient that I kind of said. When you keep going up and up and up and up on the jet pit and it's not working, then consider changing the jet eye time. You guys know the jet's a powerful ventilator. Small changes in the jet can result in CO2 coming off like crazy. You've seen it in some kids. But also, why do some kids need those jet pips of 40? And that's part of the reason too, why. Okay. So the idea is, with those more chronic kind of beat up patients, and the ones where resistance is high especially, the effective delta P penetration with the shorter TI, it's only getting down this far. But with the longer TI, it gets down this far. So my x-ray is overinflated, grossly overinflated. Does this help? I think it does. Because again, if you are more efficient and effective down here at creating those pressure gradients, the gas that's trapped up here will follow suit. And also, it's kind of a, although it's a subjective gut feeling too. You know, over the course of your shift, you've gone from a PIP of 25 to 37. Okay, if you've gone up that high and that CO2 hasn't come down, well, you know what? Going to 39 is not going to bring it down either. I mean, you've gone up quite a bit. You know, you're at pressures of 37 over 8. In theory, you should be blowing the heck out of the kid, and you're not. That might be an eye time type patient. Give us a call on the hotline. We're always there for you 24/7. Myself and just a few others, we're always on this thing. And give us a rundown of your patient and what's going on. And, because it's always, you know, standing up here and just talking about it is pretty easy. It's not the bedside, okay? So getting a rundown of everything else that's going on with the patient. All right, so we've gone over a lot today, but don't worry, it's cool. You know, if you simplify it and keep to the basics, you will always do great with the jet. The jet works best earlier. Don't wait too late to put it on. One of the reasons that the jet fails to meet our expectations is because we wait too late to put it on. And then we're asking a miracle out of a machine that, you know, where had we started it 2 days earlier, we wouldn't be at the point we are now. You know, oxygenate with a conventional. PEEP is your friend. PEEP is the lowest and safest form of positive pressure we give. Okay, you know, with kids that are on the jet, Their x-rays are overinflated. We want lower mean airway pressures. Let's optimize other things first before we start going to peak because of the resistance, especially downstream, the resistance down there. Ventilate with the jet PIP, and if we get to the point where the